I have the honor today to do our official introduction for Dr. Adrienne Scott. Dr. Scott is professor of ophthalmology at the Wilmer Eye Institute and holds the Frederick M. Leader Professorship in Ophthalmology. She's an internationally recognized vitreoretinal surgeon and clinician scientist whose work has advanced the understanding and management of sickle cell retinopathy through the application of novel retinal imaging technologies and translational clinical research. Her clinical and academic interests span sickle cell retinopathy, diabetic retinopathy, retinal vascular disease, and health disparities in ophthalmic care. Dr. Scott received her medical degree from Drexel University College of Medicine before completing her ophthalmology residency at the Duke University Eye Center, where she earned numerous honors, including the Ocular Innovation Award. She remained at Duke to complete her fellowship in vitreoretinal surgery prior to joining the faculty at Wilmer. A nationally respected educator and leader, Dr. Scott previously served as chief of Wilmer Eye Institute Bel Air and as director of the Wilmer Retina Fellowship Program, where she has mentored the next generation of retina specialists and clinician scientists. She is also widely recognized for her leadership in advancing equity and inclusion in medicine, having served as the Equity, Diversity, and Inclusion Editor for JAMA Ophthalmology. Dr. Scott has authored more than 200 peer-reviewed publications and is an active investigator within the Diabetic Retinopathy Clinical Research Network. Her work has helped define contemporary approaches to retinal vascular disease and the use of advanced imaging modalities in sickle cell eye disease. She's an active member of the Retina Society, the American Society of Retina Specialists, and the Association for Research in Vision and Ophthalmology. Please join me in welcoming Dr. Scott as she shares her expertise on the diagnosis and management of sickle cell retinopathy in her presentations, proliferative sickle cell retinopathy pearls for practical management, and sickle cell retinopathy, past lessons, future directions. Welcome.
So I'm going to get started talking about proliferative sickle retinopathy. Really like interaction. If there's any questions, please feel free to just chime in and ask any questions. Disclosures are here. None are relevant to this material. So sickle cell disease, we know a lot about it, and we've known a lot about it for a long time, which is one of the reasons why I'm really inspired to study this. So I feel like we ought to be able to solve this. Shout out to Rajiv in the back. Thank you. That's my co-resident from years ago, Dr. Ramchandran. So it's the most common inherited blood disorder. We know that it is a result of a mutation in the hemoglobin molecule that can severely impact the oxygenation delivery to the tissues. And it's very important if what type of genotype you have in sickle cell disease, depending upon the manifestation that you'll see in the eye. So genotype does not necessarily predict phenotype. But so hemoglobin S is one mutation of the hemoglobin molecule, and hemoglobin C is another, and these are the most common ones. There's like 100 or more, but these are the most common mutations we see that cause sickle cell disease. So we know this is the hemoglobin mutation that causes intracellular contents to polymerize. The cell is rigid. We used to think, oh, sickle cell disease happens because the cells are misshapen, but we have a little bit more sophisticated understanding now. This is a very complex disorder. So cells change shape, there's membrane distortion, and then you have not only cellular rigidity, but you have vaso-occlusion. And you can see with the vaso-occlusion, the nice spherical red blood cells flow through, and the sickled cells kind of stick on the vascular endothelium, and that causes this feedback loop of increased inflammatory mediators, increased vascular mediators such as our friends VEGF, HIF1 alpha is another one. So quite a bit of quite a consequence of these cells sticking to the endothelium. In addition to vaso-occlusion, you have cellular adhesion, and again that decreases the chance of the perfusion going all the way through to deliver oxygen to the tissue. So these patients are severely ischemic. And one of the cool things that's very interesting on my part to be able to look at sickle cell retinopathy and study these patients is the fact that this is going on throughout their body from birth. And then in the retina, it's the one unique place where you actually get to see it and image it and really try to understand the pathogenesis and the ultimate natural history of this. So PSR staging. So one of my mentors at Wilmer, the wonderful, famous Dr. Morton Goldberg, who's still there, in 1971 talked about sickle cell retinopathy, and he didn't have wide field imaging or OCT angiography. I'm going to show you a lot of different sort of imaging techniques, and he had basically his Goldbond 3 mirror and his astute clinical observations, and some 30-degree fluorescent angiography. But he noticed a very characteristic pattern of vascular remodeling. So stage 1, peripheral arterial occlusions; stage 2, peripheral AV anastomoses, and I'll show examples of all of these. And stage 3 is where we start to perk up, because that's neovascularization. And the neovascularization, while the patient is still asymptomatic, that's the point at which you get worried that they're at risk for visual consequence, such as stage 4, vitreous hemorrhage, or the worst is stage 5, vitreous traction leading to retinal detachment. So let's talk a little bit about proliferative sickle retinopathy, because that's the area in which we feel like it's, at this point, it's probably one of the most actionable parts where you can diagnose a problem and then try to head it off. So this is probably one of the most recognizable symbols in all of ophthalmology, definitely in, I'll venture to say maybe in retina, the CFAN. And this is characterized by an abnormal kind of frond-shaped configuration of blood vessels, and not many other things besides sickle cell retinopathy do this. There are a handful of things, but this is pretty much the hallmark. So prevalence of proliferative sickle retinopathy as high as up to 40% in hemoglobin SC and 40 to 20% in hemoglobin SS. Again, it matters what type of genotype you have. So if a patient comes to my clinic and the technician says, well, they have sickle cell, they're here for retinopathy screening, what imaging do you want? And my answer is really going to depend a lot about what type of genotype do they have. And a lot of times we have the fortune of those patients being referred by the hematology service, so that often is there in their chart. Proliferative sickle retinopathy usually occurs by 24 to 26 years of age. And proliferative sickle retinopathy does something very unusual that I don't know about any other retinal vascular disease doing this. It has this spontaneous regression, and it's called autoinfarction, in which you have the CFAN neovascular frond, but sometimes they shrink up and become less vascular, more fibrotic, and that's a good thing for the patient oftentimes, because a lot of times this can happen without the patient even being symptomatic. So one of the questions we've had for years is, why is it that you have a little bit more risk of retinopathy and sickle cell SC disease compared to sickle cell hemoglobin SS disease? Patients with SS disease are often systemically sicker. They have more morbidity, the vaso-occlusive crises. They can have retinopathy, but the patients with sickle cell hemoglobin SC disease often are at much higher risk for retinopathy. And the theory that I think is shared by the hematologist, is that in sickle SC, you have minimal oxygenation, and it's like they have higher hematocrit load, and they have more indolent blood flow, and so you have more time for transit of the abnormal cells. They do go through the vascular lumen, but it's more interaction with the endothelium, increasing risk of these bad vasoactive factors like HIF-1 alpha and VEGF and things that promote a neovascularization friendly environment. Whereas maybe individuals with hemoglobin SC, they have more complete closure, more complete ischemia. Maybe they're less at risk for neovascularization because they're more anoxic rather than hypoxic, like the hemoglobin SC individuals. So here are the challenges that I've had for myself, when I see a patient with sickle cell and proliferative sickle retinopathy. It's like, well, what are we supposed to do? And how do you know who's going to be completely asymptomatic? How do you know when you have to treat these patients? When do we begin sickle cell retinopathy screening? What imaging modalities are best to use to screen these patients? And what about laser? Do we laser? What if there's ischemia? Because there's almost always, there's distal to the neovascularization, there's ischemia. And can you laser the ischemia and prevent neovascularization? What about scatter laser? Do we still use that first line? Is that kind of old school? What about all these cool new anti-VEGF agents we have? Where do those fit in? They cause regression of neovascularization beautifully in many diseases. Where does that fit in? And how do we tell which lesions automatically or autoinfarct spontaneously? And what about systemic therapy? Sickle cell has had these very interesting innovations in which systemic sickle cell has been, they call it curative therapy, has been ameliorated by things like bone marrow transplantation or gene therapy. How does that affect what we see in the eye? So these are all questions that I personally have and still trying to find the answer to. So one of these questions is about lasers. So, when in doubt, hit the literature. And one of the best studies that I've seen is by Dr. Goldberg's group. And this is way back, and this is in 1991. And he looked at patients who had hemoglobin SC disease and proliferative sickle retinopathy. And he was able to have a good enough number where he could randomize them into treating them with scatter laser. And I don't say PRP, that's different. PRP to me means pan-retinal, meaning you're like with diabetic, you're lasering the whole retina. Scatter laser to me means something different, maybe a little bit more targeted, and that's how I use it. So basically, he treated these patients with either laser or control, and he found that in laser-treated patients, you could decrease the incidence of vitreous hemorrhage very slightly in the treated group, 11.1% versus 18.7%. It did not prevent new C-fan neovascularization from forming. It maybe prevented the C-fan neovascularization that was there to progressing into a higher stage by a smaller amount. So that's the reason why I think that's the best evidence that says that says to us when you see proliferative sickle retinopathy, consider using laser treatment. Okay. Here's an example of an image, and I do believe this was actually done by Dr. Goldberg, of a ultra wide field fundus image. You can see the C-fan neovascularization. The way that I treat patients, usually surrounding with scatter laser the C-fan frond, and probably doing a little bit more laser into the retinal periphery to the areas of ischemia while I'm there doing the laser. And I'll show you a treatment endpoint, after in a couple of slides. But this is generally my laser paradigm. This is not pan-retinal photocoagulation. It's different. And I use fluorescein angiography quite a bit because I feel like fundus photographs can help quite a bit, but then also to be able to understand the circulation, fluorescein angiography is really key, especially when you're looking for, is there ischemia, is there subtle neovascularization? So here's an example of how I do use fundus photography. This one is mine. This is my patient. So one image shows her C-fan neovascularization image, and she has quite a vascular red border of one of the vascular complexes. And then you can see I surround it. I don't know if this is a pointer. Does this show up? Yep. So I surround it with laser here. This is kind of laser out into the periphery a bit, and I use a fluorescein as a guide. But to be able to tell response to treatment, I like to use serial fundus photography because it's very simple the way I think. This is red and vascular and more active, and this is less vascular and less active. So that means maybe your treatment has been effective for what you wanted to do to decrease the risk of it progressing. Okay. Colleagues at Wilmer, led by Dr. Sodi's group, looked at eyes with sickle cell retinopathy, and they also validated the use of laser and said, well, if you're going to do laser, depending on where these growth factors are formed, this is the area in which to look at. So you have the non-perfused zone is the NP, M is marginal zone, and then the transitional zone. So Dr. Sodi and colleagues kind of thought about, well, if you really want to target where the growth factors are, not only do you surround the C-fan lesion, but take your laser a little bit posterior, and not posterior enough to cut off the visual field. Again, this is not pan-retinal photocoagulation, but just a little bit into the transition zone between perfused and non-perfused retina. And then this is an example of what I do or how I would laser a patient. Anti-VEGF. So anti-VEGF can be very helpful, but I use it mostly as an adjunct. So this was a patient, she was actually a technician, and she had neovascularization from sickle cell retinopathy, and it just kept bleeding. And I know she'd had very good laser by a colleague, and because her other eye looked beautifully lasered, but she kept having this like vascularization, and she'd come back with these like really debilitating vitreous hemorrhages. And you can see how vigorously we're leaking here on the ultra wide field fluorescein angiogram. So we gave her one bevacizumab injection, and you can see the regression of the neovascularization quite a bit. So it's shrunken up quite a bit. So it worked really exquisitely, and we don't have the right algorithm or a level 1, complete randomized study to show how do you use anti-VEGF for sickle cell retinopathy as yet. But we're looking into this. People are using faricimab. Again, no financial incentive to discuss any of that, just discussing the general principle that anti-VEGF works very well for causing regression of neovascularization. And you can see the fluorescein looks beautiful after just one single bevacizumab injection. Okay. This is a stage 4 lesion. You don't see anything here, and that's because the patient doesn't see anything either. That's what it looks like for this particular patient. Unfortunately, the vitreous is filled with hemorrhage. Interestingly, you can see if you do a fluorescein, some leakage, even though we're, obscured, the details are obscured for the posterior pole, you can still see leakage there. And then this unfortunate patient has not only retinal detachment here, but pre-retinal hemorrhage, premacular hemorrhage. This is a pretty advanced case, and these are hard cases. And so, surgically speaking, this is a surgical case. And my theory and my thought is to try to avoid taking these patients to the operating room the most possible. So whatever you have in your armamentarium, so between the close observation, serial imaging, laser, anti-VEGF, try your best to keep them out of the operating room because they're very challenging, pretty unforgiving cases. So interestingly enough, sickle cell retinopathy is primarily peripheral retinopathy, but not just peripheral retinopathy. And this is an example of a patient whom I saw. This is a 35-year-old woman. She had just known proliferative sickle cell retinopathy. She moved to Baltimore, actually from New York City. And you can see here her fundus photograph shows, hopefully it shows up, good laser. She's had reasonable laser. She's had CFAN neovascularization that's appeared more fibrotic. So it's white, it's not red and vascular looking and more prone to bleed. And then the ischemic blood vessels there. Vision decreased for about a year. Vision's down to like 2250 though. Any guesses as to why her vision would be down like that? Right. So not just the proliferative CFAN going on there, but causing the issue. And a lot of times we think about sickle cells being kind of a peripheral retinopathy, but sometimes even as you have regression of your neovascularization, you can have opacification and contraction of the posterior hyaloid, and that leads you to vitreoretinal or vitreomacular interface abnormalities such as vitreomacular traction, macular epiretinal membrane, macular hole. You can see it in diabetes. It's not unique to sickle cell, but this is one that I saw that we would do surgery on. Mark, you would observe this, you said?
Oh, yeah.
I'm just kidding. I'm just kidding. I'm just kidding.
3% chance.
I'm totally kidding. No. So we did surgery. This is one of my outstanding fellows, Dr. Anu Chopin. And we took this patient to vitrectomy. Now, the thing that did give me pause actually is that this hole had been there at least 6 months, which made me, a little worried about visual outcome after we operated. And you can see we're using 23 gauge vitrectomy at the time to segment these areas and kind of divide the vitreous in between these CFAN lesions there, and carefully trying to remove the peripheral vitreous. And the thing about doing surgery on these patients is that they're usually young. They are usually have an attached hyaloid, and they're usually phakic. These are all things that make things a little bit more challenging for us to do as to operate on. Not to mention the sickle cell retinopathy makes their analgesia something that you have to be very thoughtful about. Peri-op and post-op. So we're doing a epiretinal membrane peel here. You can see the fairly large size full thickness macular hole there. And we're gently trying to dissect the epiretinal membrane away from the center of the macular hole there. And you can tell, let's see, pretty soon we're using a pick to try to dissect away the layer of the hyaloid there. And then we do go back in, and this is our end grasping forceps to go ahead and remove the remaining traction there. And we use the cutters. Again, we don't want to be like super aggressive. We just use a cutter to try to truncate, relieve the traction and truncate some of these membranes here.
Is that a lighted pick or a chandelier?
You know what? This is a lighted pick. We did switch to bimanual technique here, which I'm a fan of. So I think it's a lighted pick here. I'm really a fan of bimanual technique usually. And then something that we do oftentimes when you peel the epiretinal membrane, you want to go back potentially and use some sort of dye. Sometimes I like to peel internal limiting membrane, or at least to go back and check myself to see if there's any residual traction there. So we can see Dr. Chopin and I kind of removing that blue, and that's kind of residual, probably a combination of residual hyaloid we have there actually peeling. But if I peel the ILM from over the macular hole, it convinces me that I have all the vitreous traction. Okay, so this is what she looks like about 6 months post-op. This is, a success of the fact that it's not an open full thickness macular hole, but you can tell, I mean, and you have these little these little these lucencies there, and that's pretty standard sometimes when you have closure of your macular hole. So you're successful, but the vision often lags. The other thing that makes me a little worried again about this patient is the ellipsoid zone layer is somewhat irregular there. And so, I mean, we got the hole closed. She's an anatomically successful. Okay. So talking a little bit about proliferative sickle retinopathy, switching gears to how do you manage patients who are surgical candidates. So these are tough cases, as I mentioned, and why. These patients, wherever you see ischemia on your peripheral exam or on your fluorescein angiogram, the retina is thin. And in surgery, you have to be very cautious for kind of tugging at that retina or trying to delaminate tissue over the retina or peel membranes over that tissue because it's very prone to causing breaks. These patients will get spontaneous breaks on their own, even outside of neovascularization and traction. Also being worried about intraocular bleeding when you're dealing with CFAM lesions, systemic vaso-occlusive crises. Again, the eye is connected to the patient, and the patient may or may not have lots of systemic crises, and we have lots of patients that have to be regularly transfused by our hematology team. So good communication with your anesthesiology team is really important ahead of time, and even better if the patient has a hematologist, really trying to understand what is the patient's need for systemic management of their systemic sickle cell. And then you have anterior segment ischemia. This used to be really common, and this is a picture courtesy of Dr. Goldberg. And fortunately, I have not had this, but I think it's has to do with the time and the innovations that we've had in modern retina surgery, where we didn't have the elegant, intricate vitrectomy systems that we have now. A lot of times it was, the buckles, and so we often put on a very high tight buckle to repair some of these detached retinas. And that a lot of times would cut off circulation to the anterior segment and result in anterior segment ischemia. And unfortunately, I think this is an eye that has a very poor prognosis. We don't see very much of that these days. So just to summarize this particular segment of this particular talk, so in sickle cell retinopathy, related retinal detachment surgery. Also, I may consider bevacizumab maybe 3 days before surgery in select eyes. What does that do for us? I kind of extrapolate from the proliferative diabetic retinopathy literature, where you give an injection maybe a few days before. Perhaps that might be able to decrease the vascularization of your lesion and facilitate the dissection of your lesion and have it bleed less, having you less likely to increase eye pressure in these patients that are very sensitive to elevations in eye pressure. We used to, the teaching a lot of times was avoid buckles in these patients. I think I have evolved from that given the type of buckles that we have available to us these days. We no longer just have those super wide, tight, super gigantic buckles. A low and segmental buckle can be helpful. As I mentioned, this is peripheral pathology. A lot of these patients are young, their hyaloid stuck down, so a buckle can be your friend. Just have to use it very thoughtfully. General anesthesia or subtenon block over retrobulbar block. Why is that? In some patients, I found that if retrobulbar block increases your pressure, even transiently, they can be very sensitive to ophthalmic or optic nerve infarction, and even with increases in the intraocular pressure that are transient. So I tend to avoid retrobulbar block in these patients. Communication with the hematology team and really kind of understand some of these patients are on chronic anticoagulation, and some of these patients are on really chronic pain regimens. So this isn't the type of patient you'd say, okay, 2 extra strength Tylenol and I'll see you tomorrow. You just have to be aware of those things, and careful communication and understanding intraoperatively between your team. This patient has sickle cell disease. Sometimes if the room is too cold in the operating room, that might facilitate a crisis. You want to be very generous with the hydration for the patient, oxygenation, and again, close attention to intraocular pressure. So screening guidelines, how do we screen? So generally asymptomatic patients with sickle cell disease are referred by their primary care team or hematologist for dilated exam beginning at age 10. And that is called expert consensus evidence. This is not based on really level 1 data as yet. And why is that? Because if you see a kiddo that's 10 years old or younger, they're really unlikely to have proliferative sickle retinopathy. And so, generally speaking, I like to see them even earlier. just because it gets the kids into the habit of seeing me, seeing me yearly, getting the imaging. And the families are very engaged. A lot of times sickle cell patients unfortunately have you have some people that don't necessarily, seem as engaged with their care, and it really just depends. But when I see the patient earlier and they understand that sickle cell can also cause a retinal problem, and at least once a year, it's good that we check to make sure and we can compare how you're doing. I think patients really appreciate that, as do families. So we're working on getting expert consensus guidelines to be able to get an evidence base behind what we're talking about for sickle cell retinopathy screening. So just to summarize this proliferative sickle retinopathy challenges that I asked myself, when do we begin screening? To summarize, at age 10, for me as young as 5, when they'll sit for me. I have patients that have even had a fairly decent OCT angiography scan as young as 4. Not everybody, because OCT angiography is often requiring a very steady patient, clear media, but if you get the right patient, they're good, and you can image them. What imaging modalities would be best to screen these patients? There's really not a consensus. If you probably ask 10 retina specialists, you might get 5 or 6 different answers. So a lot of people don't do any imaging. Some people just do clinical exam and say there's no neovascularization. Okay, we're good. And that's okay. I get a lot of imaging because I have the interest in seeing these patients and understanding the pathogenesis behind their disease, as well as my own research nerdiness. So generally speaking, I say immaculate OCT at least annually, and ultra wide field fundus photo and fluorescein angiography at baseline and annually, especially if the patient has proliferative sickle retinopathy history. Have your antenna up for peripheral retinal pathology in patients with the genotype hemoglobin SC or hemoglobin SC or sickle beta thal. Also monitor for vitreoretinal interface abnormalities. We talked about macular hole, vitreomacular traction, epiretinal membrane. Do we treat peripheral ischemia in the absence of neovascularization? No. And do we use scatter laser first line in proliferative sickle retinopathy? Does anti-VEGF have a role? I use scatter laser first. I use the wide field imaging to guide my scatter laser. If it's still bleeding or still vascular, or the patient still says, I'm still getting hemorrhage or floaters, then that tells me, wow, this may be somebody that anti-VEGF may be a good adjunct. I don't like doing it into a treatment naive eye. Also, you could consider anti-VEGF pre-op to maybe facilitate your vascularization. And what about systemic therapies and these great innovations that have been made for sickle cell patients? Most of our patients are pretty well cared for. There's a dedicated sickle cell center at Johns Hopkins in both pediatric and adult. Hydroxyurea has been the mainstay, but there are lots of other medications that are in the discovery phase. Interestingly enough, we talked about hemoglobin SC as having the higher burden of proliferative sickle retinopathy that's potentially vision threatening, but they don't have anything, meaning there's no systemic thing that's ever recommended for them. Some people will put them on hydroxyurea. It's controversial even among hematologists. So we're looking into that and trying to understand what can a sickle cell SC patient have to be able to decrease their risk of progression to retinopathy. And then spontaneous autoinfarction, that got 3 question marks because I still don't know and understand that. Why do some people have spontaneous autoinfarction and some people have progression of their proliferative sickle retinopathy and neovascularization? We still don't know what this phenomenon is really based upon. I want to thank the team, including the hematologists that refer us all these patients, and the various research team that's helpful in helping us to analyze some of these data points, and many fellows and residents who've helped me along the way with these types of presentations and taking care of these patients. So, thank you. Any questions? We're booting up the next Dr. Wozniak. I'll give you the first.
I have a question. So on your last slide, you said if there's ischemia but no neovascularization, you don't treat. Is that because the incidence of kind of converting to neovascularization is really low, or it doesn't? I guess it seems logically that maybe you would, but I don't.
Yeah, it's more like it just really doesn't help. Like, I just don't think it prevents the problem. Like, I don't think it's wrong, but I don't necessarily think it helps. I mean, I've tried that. I just really don't think, and I extrapolate a lot from a lot of these big studies were done in people who, diseases with higher prevalence, like branch retinal vein occlusion, and they've tried to laser peripheral ischemia and branch retinal or central retinal vein occlusion, and found that it really kind of makes sense to laser once there's actual neovascularization. So. Great question. Yeah.
What about auto-refracted cases? Will you still go ahead and do standard laser?
That's a fantastic question. Typically not. And the reason why is if it's auto-infarcted, that's like my goal of treatment. And I try not to induce traction with my laser or whatever treatment because you can get abrupt contraction of the posterior hyaloid and cause a visually asymptomatic person to go, "Oh, I was fine until till your treatment." And that's somebody I would watch. I would watch very carefully. But if it's whitish, fibrotic neovascularization, I tend to observe if they'll come back regularly for me.
I think it's great with the surgical approach with that macular hole case. I was curious when you do take the nasty TRD RD combination ones, how in your experience is there approaches that are similar to PDR cases that are like that, and how it's different for sickle cell and what you recommend for that?
That's a really great question. I mean, I think I have a lead in this talk too that, and I think about that a lot. I think the differences are that again, the pathology in proliferative sickle retinopathy is going to be more peripheral as opposed to a little bit more posteriorly located. So working in the periphery and and they're usually young patients, they're like 20 and 30, and they're always phakic, and so it's a little bit challenging. I like bimanual technique for both, and I like considering anti-VEGF preoperatively for both, but they have some similarities and some differences. The differences mainly is you're working in the periphery in a lot of these cases, so you have to be careful of the lens, and the hyaloid's always stuck down. So, yes.
Should we be considering lower IOP goals in all intraoperative surgeries? So, for example, cataract surgery for these patients. And what type of IOP goal are you looking at?
That's a really great question. I mean, I think that we don't yet know is the short answer. I think it's very reasonable when you have a patient to understand kind of what their systemic issue is and to try to avoid prolonged elevation of intraocular pressure. You have some patients just kind of leave them at, 35, 40, they'll be fine. But there's some patients that I think in these patients have to be very careful and thoughtful about how long the pressure is elevated and for what reason, and do you really need that? I think it's nice for anyone operating these patients to just be aware of anything you would potentially do to elevate the pressure. For example, do you have any cornea specialists? Yeah. Do we still do the Honan balloon? I don't know. That's old. That's really old, right? So anything that you do to kind of elevate their eye pressure is something that we would want to avoid. That's why I avoid blocks in these patients. That plus, oftentimes it's so hard to get these eyes numb. I tend to prefer general anesthesia where possible in these patients, and subtenons if that were contraindicated. Yep, please.
Yeah, you mentioned it briefly in the first part of your talk. Can you give us a quick update on the status of gene therapy for SCR? Because it's discussed as one of the most exciting emerging gene therapy prospects. And so if this is an effective therapy, do you expect SCR cases to plummet in the next 20 years?
That's another really good question. A lot of the answers to those questions are in this portion of the discussion. Short answer is no. And the reason why is I always go back to this expression, the horse is out of the barn. It's kind of like by the time you see neovascularization or really bad sickle retinopathy, whatever's happening, it's not necessarily affected by the gene therapy. Gene therapy is FDA approved. It is considered curative for patients with sickle cell disease, but I don't think it necessarily directly affects the retinopathy that we see. It's kind of like, it's already, the damage has already happened, but a lot of these things are up to future study, and that's one of the things that we're interested in. Great. Thank you for these good questions, and thank you for being so engaged for Friday afternoon. This is amazing. All right, I'll try to zoom through some of these things that we've already heard of as a lead in. Okay, and get to kind of the meat of this. So we know all about sickle cell disease now, and sickle cell disease unfortunately affects every part of the body. And we've got the brain, the lungs, the bone, the kidneys, and then of course the eye. And we know hyphema unfortunately is considered an ophthalmic emergency in patients who have sickle cell because again, even elevations in their intraocular pressure, their optic nerves are very susceptible to infarction from high pressure, high eye pressures. I don't know if these are visible or not. These are little conjunctival blood vessels that are called comma-shaped vessels. So anybody has extra time in clinic, like we all do, you can just sit and stare and who's had time for this? I don't know. But you can see the actual blood vessels, right? So if you have patients at the slit lamp and you ask them to look up and you shine a high mag, you could see it's really kind of interesting. You can see the blood vessels, this box covering effect going through the conjunctiva. And this is a patient with hemoglobin SS disease, and the lovely iris. So you can see this is a patient who had proliferative sickle retinopathy, well treated. But this was a picture of his irides. So he had all this iris atrophy bilaterally. It's pretty striking. And sometimes we see this in patients who have proliferative sickle retinopathy, even if it's treated. So if this was a New England Journal of Medicine, so if you're an internist, you can say, oh, if you see this, it just means that, just be like, oh, the patient could have retinopathy, so it's just maybe a little biomarker or a little linkage for maybe there's some proliferative sickle retinopathy there. And the optic nerve, little bitty comma vessels as well. And we're basically seeing little manifestations of the same thing. Blood vessels are getting stuck in these precapillary arterioles everywhere. And then as ophthalmologists, we can actually see it. Okay. What about the macula? And we talked a little bit about vitreoretinal and abnormalities from proliferative sickle retinopathy, but this is probably one of the most common things you see in patients with sickle cell. It's these macular thinning. The macular thinning is pretty common, and we don't know yet if they have any visual sequelae from it. In fact, we check distance vision in the retina clinic and we think probably they don't, although there have been some microperimetry studies and some studies that have shown maybe they have some either near vision problems or a decreased contrast sensitivity. But their maculars are weird looking. And this is so common that this was actually presented in Academy a couple of years ago, almost like pattern recognition. And I'll show you what I'm looking at. So these are, this is an OCT, had a B-scan map here, and it's a control, nice smooth dip. That's what we want. These are OCT angiography images of the superficial and deep capillary plexi. The foveolae vascular zone is blue. So anywhere there's blue means there's not blood flow, okay? So when you look at the control, and I like this as I call this a tale of 3 10-year-olds. So this is a controlled 10-year-old with no hemoglobinopathy. This is somebody with hemoglobin SS, and you can see this like weird flattening of the retina, and you'll see this on patients. If you image them, this is what you'll see. And then you can see in the OCT angiography, they have these little bits of decreased blood flow on their map, superficial capillary, and usually the deep is affected more than the superficial capillary plexus. And this is hemoglobin S variant, and that's what our hematology team calls the hemoglobin SC or beta thal patients. And again, flat retina, their contour is gone. You can see a little bit of decreased blood flow in their superficial and deep capillary plexus, all 10 years old. And this is Dr. Sally Young, who's now on faculty at Wake Forest. She's one of our Stello Retina Fellows who helped put together this series. And we really tried to understand how was it that, how did this happen? And by looking at kids, sometimes you can understand a little bit more about disease pathology while the individual is young. So sickle cell maculopathy. So this is, again, very, 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 very common. And so this is probably my go-to test. If I have a patient who's coming in for sickle cell retinopathy screening, I look in the periphery, I don't really see anything. I'll oftentimes follow them with serial OCTs. And here's why. So Dr. Jennifer Lim at the University of Illinois has been very productive in following these patients with OCT scans. And you can see the maculopathy is common, and patients with sickle cell disease will often have a thinner macula than patients who don't have sickle cell disease. And people who have sickle cell disease and take hydroxyurea, which is the first kind of gold standard treatment for sickle cell disease, have decreased rates of thinning. Also, Dr. Lim correlated age and stage of retinopathy with higher thinning rates. So if I can give you one take home, sometimes I put this up in the exam room and show the patient and I kind of explain hydroxyurea is a little bit of a controversial treatment, and the reason why is that's got a lot of side effects. So it is not so great for fertility. It can cause alopecia. It can cause, skin problems, and all the things you don't want to hear when you're like, adolescents to 20s or 30s when this is being recommended. But I will show this because it can be protective to decrease risk of vaso-occlusive crises. It is relatively, at this point, at least affordable, and it is protective against the thinning and maculopathy. Okay. So in this cohort, again, we found that decreased vascular density was common to those without without a difference in retinal thinning compared to controls. So that told us that perhaps microvascular abnormalities can precede structural retinal thinning. Again, these are patients, they get crises from birth. When their fetal hemoglobin goes away, they have these little mini crises in the eyes. When you have them in your hands and legs and back, you feel them, but you have them in your microcirculation of your macula, you don't feel them. And because we saw in OCT angiography, there was decreased vascular density in some of these individuals, while having a normal contour, our hypothesis is that the decreased vascular density precedes the actual structural thinning. Okay. And then just talking a little bit about peripheral retinopathy that we know sickle cell retinopathy to be. So again, how do I follow my patients? This is a patient of mine in 2025. Again, she moved from out of state just for follow-up, hemoglobin SC. She's got good laser. She had these little C-fan. Do I laser every single C-fan that's small? No, I do not. I follow if I feel good about the patient following up. But I look and I try to do serial imaging on them regularly. And if I feel like there's progression. So when I got this picture, I was kind of like, did I miss this all these years? What? I mean, I just was like big old C fan. I was like, what? I see this patient every 6 months. I'm like, why, what did I miss? And I look back, I'm like, nope, she didn't have it last year. So that's one of the encouragements I'll get for serial imaging in these patients, especially if there's pathology and you're on the border about treating. Okay. We talked a little bit about staging. Non-proliferative sickle cell retinopathy, we have these dark black sunburst spots there. And then these salmon patch hemorrhages here, you'll see very commonly, they're considered blowout of these arterioles. And these are, again, visually not symptomatic. You have a black sunburst here. And these are people who just watch, see you back in a year, usually don't have much visual sequelae. To Dr. Brizzano's question, we really want to find out individuals who have proliferative sickle retinopathy and to be able to understand who's more likely to progress. So I really like this case by Dr. Folgar and colleagues because it has an OCT of neovascularization of a C-fan membrane in a patient with sickle cell, which is up top here, compared to diabetic proliferative retinopathy. So the hypothesis is that perhaps both have neovascularization. Is all neovascularization the same? No, because it looks like the sickle cell patient has more of involvement of the nerve fiber layer, ganglion cell layer, while the interplexiform and internuclear layers may be intact. And then a diabetic neovascular membrane shows more involvement of the retinal nerve fiber layer, ganglion cell layer, inner and outer plexiform layers. So they're deeper adhesions there. And so that may inform your dissection as well. Talked a little bit about proliferative sickle retinopathy treatment. So we have a little bit of time up. I'm going to kind of dive into some of the.
Your patients have vaso-occlusive events or pain crises. Do you have them come in sooner than if they're being seen, Q year or something like that? You say, hey, you're in the hospital, like just let us know and we'll see you sooner, or do you just kind of keep it the same?
No, because what I would say was I like to see them for a baseline, and I kind of oftentimes punt to my hematology colleagues or whatever the person needs. They need exchange transfusions. Do they need hydroxyurea? Are you thinking about them for bone marrow transplantation? We're doing a lot of that at my institution, or gene therapy. Whatever you're doing systemically, I would say keep doing it for the crisis part. I feel like we're kind of seeing a window of what's happening in the overall body. So I will not ask them to come in sooner. But thank you for the question, and I'm going to go for 5 more minutes and then leave time for questions. So this is an individual that I thought was really fascinating, and this is a patient of mine who has hemoglobin SS. Well, I told you already that hemoglobin SC patients are the one that have the most pathology, but both genotypes can have that. this was pretty striking because of all this neovascularization this person has, but it appears infarcted in both eyes. You can see the extent of neovascularization, almost 360 in both eyes. And if you do a fluorescein angiography, it will leak. It will leak. Doesn't necessarily tell you if it's active. To me, it'll always leak when you have incompetent vessels. Now, is it leaking a little bit or is it leaking a lot is different. But to me, I don't make a decision based completely on fluorescein angiography. I have not treated this patient. He's been like this. I've been following him for like, I don't know, 4 years or so. But when you see him, it's interesting because he is very much affected by the sickle cell, very thin, a lot of pain crises, high burden of morbidities from sickle cell. And I feel like that's what we see as ophthalmologists a lot of times, that we can see kind of what's happening with your overall ischemia throughout your body. But I didn't treat him because it's not red, it's not vascularized, it looks burnt out, and he's such a good patient. He'll let me kind of see him follow up for serial exams, and he's not symptomatic. I'm going to share a case, and I think I'm going to knock it off here. This is a 24-year-old man with hemoglobin SC, complained of decreased vision in the left eye for about 4 months. He has stage 3 in both eyes and is known to have that. This right eye here, does it look okay? Does anybody think it looks okay? Normal? Anybody? No, Jay doesn't like it. Yeah, me either. This is something, right? This is something not right, right? And then that one, I don't like it either. Okay, but he's asymptomatic here. I agree with you. Okay, we do the fluorescein. It can tell you this is an area that's leaking. He's got AV anastomoses and then decreased vascular perfusion. OCT, to the earlier point, you can see flattening even in this asymptomatic right eye here. And you can see I really like the map, and the map can really point to where is he thin. You're supposed to be thin in your foveal center, but look, all this is not supposed to be thin, but goes with the disease. This is his left eye, and this is somebody that was referred after he'd had laser in the community for this CFAN neovascularization that appears actually kind of auto-infarcted already. But the person did great laser, but kind of vigorous laser. And, this is subretinal fluid now. And so that's the reason why this person is here with me for treatment. You can see leakage of the CFAN complexes and then peripheral ischemia. And all right, you're on a roll, Jay. Bad or good? What do you think? You like it or no? You don't like it?
Well, it's way worse than the other side for sure.
We don't like it. It's subretinal fluid, right? It's bad. It's like, oof. Okay. So that's why this person is now a surgical candidate. So I'll show you what we did. So we did take this person to surgery, and while we were waiting to get him to surgery, he actually got a little bit lucky because I think he's pulling up his Weiss ring here. So, it gave us a plane to go ahead and start our dissection. We put in some triamcinolone, did some dissection of the Weiss ring. And so it almost gave us a roadmap about what to do. So we think that's the culprit. We use bimanual technique, including a lighted pick, to be able to peel off the CFAN fibrotic complex and then draining subretinal fluid. And the Schlering, that's the proteinaceous chronic subretinal fluid. We're kind of flattening his retina and adding laser here and kind of supplementing his peripheral laser and ending the case. And to the point earlier, I think laser wasn't a wrong thing to do, but sometimes if you already have an auto-infarcted CFAN complex, what can happen is if you're too vigorous, it's kind of like that crunch phenomenon where if you do too much laser, the posterior hyaloid can contract, and these retinas are thin, and if contract, pull on the peripheral neovascularization, and then this person unfortunately had a detached retina. But he did well. This is him. I put him under oil. This is him post-op here, return of his foveal contour. Again, ellipsoid zone abnormality, don't like it. And then the thinning of the macula, which we talked about, goes with the disease. Got him to about 20/40. He's about 4 years post-op now, and this is what his retina looks like now after he's had his cataract removed as well. So just a few minutes left. I'm going to knock off here. Thank you for your attention. I want to take any questions.
Adrienne, can
Yeah.
you talk a little bit about your work in Africa and West Africa and the populations there where there's a lot more probably population who have sickle cell? And are you working with the hematologists in Hopkins with that population as well?
Yeah, that's a great question. In the burden of the sickle cell disease is shouldered by the African continent, and there's a whole group, a consortium called sicklecellretinopathy.net. And say, okay, is there a diabetic clinical research network? .net. Yes, there is, but now there's a sickle cell retinopathy research network, and it's really led by a lot of the retina specialists and hematologists and caretakers who are from the African continent. And so I collaborate with them, and we put out certain things talking about global disparities. Interestingly, I have learned that people who have sickle cell, for example, in Africa or other countries, it's more of a morbidity issue. Like they're trying to live as opposed to, all these fancy images and all this, things that I'm doing and this, very expensive surgery. A lot of times it's a matter of, well, can you access hydroxyurea? Oh, can you get to the hematologist? It's also interesting because there's a big stigma around sickle cell disease in certain areas where even saying that you have sickle cell disease can make people think that you're weaker or you're not, for whatever reason, you don't want people to know. So just trying to work with those groups to understand a lot of those, different treatment paradigms and trying to use a lot of what we've learned from all these resources, all these expensive tests to be able to try to extrapolate what can happen over in the African continent.
Was that a 360 peritomy in that eye? Was there a decision to do a buckle and maybe not do one, or worry about obviously anterior segment ischemia sounds like it doesn't happen anymore, which is great. But
Well, yeah, this is when I don't think I did a 360 peritomy. So I don't know if we took down the conch for some reason, but I don't. I usually would not unless I were putting on a buckle, which I will, if, for example, if I had a patient that, failed initial repair and I thought there was a peripheral CFAN that was just too big and I wanted to support it peripherally. Buckles can actually work very nicely. So in the select patients, I'll do a low buckle. Anything else? Thank you. Thank you all for your time and attention.